Greetings from ECS Heart. My name is Dr. Joseph Marine from Johns Hopkins University in Baltimore, Maryland, and I'd like to speak to you today about evaluation and treatment of vasovagal syncope. Vasovagal syncope is extremely common, with a lifetime prevalence of somewhere from 20 to 30% of the entire population at some point will have a fainting episode. The presumed mechanism of vasovagal syncope is that blood pools in the legs, triggering a hypotensive response, which in turn triggers a catecholamine surge, causing the heart to pump more strongly, and therefore triggering a vagal response and a vagal efferent to the brainstem that then triggers a vagal afferent, causing a slowing of the heart rate and a fall in peripheral resistance, and that leads to a drop in blood pressure, a decrease in cerebral perfusion, and loss of consciousness. The key steps in treating vasovagal syncope is, first of all, to make an accurate diagnosis, and that requires a careful history and physical examination of the patient. There are certain characteristic symptoms patients have from vasovagal syncope, including having a prodrome of warmth or nausea, syncope that occurs in the setting of prolonged standing, syncope that occurs repetitively over a course of many years is more likely to be vasovagal than to be cardiac. It is very important, however, to do an electrocardiogram in every patient that has any kind of loss of consciousness, looking very carefully for signs of structural heart disease, looking for signs of conduction disorder, and looking for signs of inherited heart disease such as Brugada syndrome, long QT syndrome, or Wolff-Parkinson-White. In patients in whom there is any residual concern about structural heart disease, it is important to obtain an echocardiogram looking for signs of valvular heart disease, pulmonary hypertension, or ventricular dysfunction. Another step that is sometimes taken is tilt table testing. So tilt table testing may be indicated in a patient in whom there is a suspicion for vasovagal syncope but not yet sufficient evidence to make a diagnosis. Importantly, however, if there is a clear history of vasovagal symptoms, one does not need a tilt table test to confirm the diagnosis. Once one has the diagnosis of vasovagal syncope, the approach to the patient starts with the cornerstone of patient education and reassurance that they have a benign condition. Patients should be assured that they get adequate fluid and salt, and patients should be taught that when they experience the prodrome of a syncopal spell, to get themselves in a safe position with their feet elevated. They may also try certain counter-pressure maneuvers which can be taught to the patient. If vasovagal syncope is still recurrent, one can consider medical therapy. Probably the single most effective medical therapy is midodrine, which is taken in the dose of 10 to 15 milligrams 3 times daily. There are other medications that have a less established evidence base. And for patients who have truly refractory vasovagal syncope with a component of strong slowing of the heart rate, one may consider pacemaker therapy, but that should really be reserved for very, very few patients who are refractory to all other therapies. So today we've summarized the evaluation and treatment of vasovagal syncope, and I hope that you found this helpful. Thank you.